Hello everyone. Today the topic under discussion is urinary tract infections in children. My name is Dr. Nayyar Raza Kazmi and I am a pediatrician. So on a starting note, UTI is one of the most common bacterial infections of childhood. Among febrile infants, unwell children in general practice and older children with urinary symptoms, around 6% to 8% will have a UTI. Now the prevalence varies with age. It peaks in young infants, it peaks in toddlers, and some of the older adolescents. It is more common in female and uncircumcised male infants, which is understandable because given bacterial skin flora concentration under the nappy in infancy, also the shorter female urethral distance, and the foreskin surface area in uncircumcised males. Now, during toddler years, toilet training can lead to volitional holding and bladder-stasis, promoting UTIs. The prevalence peaks again in adolescent females when sexual activity disrupts bacteria near the urethral orifice. Now keep in mind that conditions that impair urinary flow increase the susceptibility to UTI. Avoiding flushes bacteria out of the urinary system, and therefore impaired urinary flow leads to urinary stasis, which can give rise to bacteria having an increased reservoir and more time to establish infection. Causes of disorder voiding can be structural, like congenital urogenital anomalies, or it could be functional, like a neurogenic bladder, constipation, and behavioral withholding. Altered immune function can also increase the risk of uncommon viral and fungal causes of UTI. I would say over 30% of children with UTI will have recurrent UTIs. And the common risk factors for recurrence include what we call as VUR, vesical ureteric reflux, and bladder bowel dysfunction. Some of the older non-continent children, like those with developmental delay, also have more recurrent UTIs. Therefore, being such a common infection, UTI contributes a significant economic burden to the healthcare system. Use of evidence-based management therefore has the potential for significant cost savings in such a scenario. Now coming to the etiology. Most UTIs are caused by gram-negative coliform bacteria, which arise from the fecal flora, which is colonizing the perineum, which enters and ascends the urinary tract. Now, E. coli is the most common uropathogen responsible for approximately 80% of pediatric UTIs. The uropathogenic E. coli strains, they possess specific properties such as fimbria, by which they attach to the uroepithelial surface to allow them to overcome host defenses. Other common uropathogens, they include Klebsiella, Proteus, Enterobacter species, and some of the Enterococcus species. Now coming down to the types, UTI can be categorized anatomically into upper and lower urinary tract infections. The upper tract involves infection and inflammation in the kidneys, which we also call as pyelonephritis, and it can also include the ureters. This typically leads to abdominal pain and loin tenderness with some systemic features such as high-grade fever, anorexia, vomiting, lethargy, and malaise. Lower UTIs involve infection within the bladder, which we call as cystitis, and urethra, with localized symptoms such as lower abdominal pain or suprapubic pain. It can lead to dysuria, urinary frequency, and urgency. Older children may also present with signs and symptoms suggesting the site of infection. But in younger patients, these classical signs are often absent, and the differentiating features between upper and lower UTI is very less obvious. Now, acute UTI encompasses the full spectrum of severity from mild dysuria in an otherwise well child to life-threatening urosepsis. While serious infections are less common, they can and they do occur, particularly in neonates. Now, since routine immunization for Haemophilus influenzae type B and the Streptococcus pneumoniae, UTI has become a more common cause of occult and serious bacterial infections in infants. Short-term morbidity can arise from the infection within the renal system, and this includes some systemic features including poor oral intake. It can include dehydration and some uncommon local complications including like perinephric abscess formation. Short-term morbidity also arises from hematogenous uropathogen spread to the rest of the body. Bacteremic UTI has been studied in infants, and this population is most likely to have blood cultures collected during a febrile episode. And approximately 5% of the infants less than 12 months of age with UTI have bacteremia identified depending on the study setting. And remember, bacteremia can then lead to urosepsis. Meningitis can also occur rarely with hematogenous spread to the cerebrospinal fluid. Now, the risk of coexisting meningitis and UTI is very less. It's around 1% in the neonatal period, which suggests a low threshold to perform lumbar puncture in this age group. But beyond 1 month, this risk is quite smaller. Typical empirical UTI antibiotics have got very poor CSF penetration and inadequate duration to treat bacterial meningitis. Therefore, long-term morbidity follows renal injury and scarring from upper tract UTI. I would say around 15% of the children with first UTI who have follow-up scanning will have this evidence of renal scarring. And this scarring would be clinically important if it led to renal dysfunction, which can lead to hypertension and sometimes chronic kidney disease. Now, historical thinking suggested that these sequelae were quite common, that led to aggressive imaging guidelines to identify children at risk of chronic kidney disease. But the recent data suggests that the risks are much lower. A study done in 2011, which reviewed 1,576 cases, found no cases where childhood UTI was a main cause of subsequent chronic kidney disease. And of a further 366 patients, 13, that was 3%, had a history of UTI in childhood, but all had renal abnormalities evident on renal ultrasound, and recurrent UTI was possibly the cause of chronic kidney disease in only one case, that amounted 0.3%. Therefore, in absence of structural renal anomalies or recurrent UTI, the risk of chronic kidney disease appears minimal. Now, debate about this post-UTI renal scarring still continues till date. Okay, now clinical features of pediatric UTI are remarkably non-specific, especially in the younger children. Diagnosis can be very challenging, but it is important to consider, especially for infants with fever without any focus of infection. Now, as far as history is concerned, young, very preverbal children cannot report symptoms like dysuria. They can't tell you about abdominal pain. So parents often notice non-specific signs. They would say like he's lethargic, he's got irritability, he's got poor feeding and vomiting. These symptoms overlap with many other common and benign viral infections, as well as with serious bacterial infections. And fever is often present. It may be the only feature present, or sometimes a child may be afebrile even. Now, malodorous or discolored urine may be obscured in nappy-wearing children, though older children may report some of the localizing symptoms such as dysuria, flank pain. Now, if you examine, on examination, children with UTI may appear very well or maybe very unwell. So fever, abdominal tenderness, dehydration, you might identify it. Localizing signs are more common in older children. Now, as clinical diagnosis is very unreliable, a urine sample is required for further evaluation. So you do need a urine sample. Now, continent children, they can void on request to provide what we call as an MSU, midstream urine sample, into a sterile collection jar. Now, the first voided urine flushes skin flora away from the urethral orifice before the sample collection from the middle of the urinary stream. Therefore, cleaning with soap and water before MSU further reduces the risk of contamination. However, as far as pre-continent children are concerned, these very young children in the Western society generally do not achieve urinary continence, I would say around until 2-3 years of age. So other collection methods are required for pre-continent children. Non-invasive methods involve waiting for spontaneous urine voiding, and then what we call as an opportunistic collection with a nappy pad, a bag, or a clean catch of urine stream. Now, these methods, they seem convenient and practical, but remember, pads and bags have got high rate of contamination, in some studies up to 50 to 60%, which is understandable because they've got close contact with skin under the nappy area. Now, pad and bag samples can sometimes be useful for dipstick screening, but are unreliable for culture. Cotton wool ball collection is specifically discouraged here in the UK. Clean catch has the lowest contamination of all these non-invasive methods, and it's around at 25%. but attempts can be sometimes can be time consuming, sometimes it can be unsuccessful. Therefore, simple voiding stimulation methods such as the quick V technique can increase the speed and success of clean catch. Some of the invasive methods extract urine directly from the bladder by urethral catheterization, or what we call as suprapubic aspiration. These methods can be effective, but they do require expertise and they do require equipment to perform. They are painful and they're quite distressing for the child. But contamination from catheter and suprapubic aspiration is low, somewhere around 10% and 1% respectively. So these methods are reliable for culture and diagnosis. Now, the optimal collection method remains very controversial, I would say. Each method has advantages and has got disadvantages, and the current guidelines have got different recommendations. Here in the UK, where general practitioners provide primary care, the guidelines, they recommend clean catch or other non-invasive methods if the clean catch is not possible. And they also advise catheter or suprapubic aspiration only if non-invasive methods are not possible or not practical. In the USA, where pediatricians often provide primary care, guidelines recommend the opposite. That is, the catheter or suprapubic aspiration is required to confirm UTI. Though convenient methods such as urine bags can be used for most of the screening, and even in the United States. Most international guidelines at the moment recommend catheter or suprapubic aspiration as the gold standard. It also includes clean catch as an acceptable collection method, and all of them specifically discourage the use of back samples for a culture. A two-step process in which you can use initial bag screening and then catheter confirmation of positive screens can further reduce the rate of invasive procedures. Because clinical diagnosis of UTI is quite unreliable, so many children with fever or symptoms of UTI need a urine sample to exclude or make the diagnosis. A urine sample should be collected before starting any antibiotics, but therapy should not be delayed in the subject child. And this is very important. Children with localizing signs or suspected UTI do need a urine sample to confirm the diagnosis. Now, children with fever, especially without any focus of infection, especially neonates and infants, they do need a urine sample to evaluate a potential UTI. Now, outside early infancy, and if the child is not unwell, it may be reasonable. You can wait for 24 hours for collection to see if you can find an alternative focus. Children with an alternative focus of illness, where you find it, they generally do not need a urine sample. Well, except there are exceptions like septic kids, children with predisposing conditions like those having renal anomalies, children who have got risk of developing complications like having a single kidney, and like in febrile illness, which is not following the expected clinical course and the child is not getting better. And now coming to screening. Now, urine dipsticks are a quick, inexpensive bedside screening tool. Chemical reagent strips, they change color in the presence of what we call as leukocyte esterase enzyme. And this enzyme is present in the leukocytes and also on the presence of nitrites, which may arise from UTI. Leukocytes generally appear in the urine in response to a urinary tract infection. But sometimes sterile pyuria can also occur with other infections like Enterococcus, Klebsiella, and Pseudomonas species. But they are less likely to produce pyuria than E. coli in children with most of the symptomatic urinary tract infections. Most of these uropathogens, they convert dietary nitrates into urinary nitrites. However, not all do, including Enterococcus and Klebsiella species. Now, dipsticks are also less reliable in young infants where, the frequent voiding flushes substrates out of the bladder very quickly. Now, neither leukocytes nor nitrites are fully sensitive or specific for UTI, but they are a very useful screening test, particularly when used in combination. Now, if you think UTI is unlikely, dipsticks have got a very good negative predictive value to exclude the diagnosis. Now, in the presence of suggestive symptoms in either leukocytes or nitrites, empirical antibiotics can be used while you are awaiting the culture. Urinary microscopy also identifies leukocytes and bacteria. It augments dipstick screening. Now, moving on to diagnosis. Now, laboratory culture is the gold standard for UTI diagnosis. Urine is sterile normally. Therefore, the presence of bacteria in sufficient quantity with concurrent evidence of active infection do suggest an UTI. Now, urine is added to a growth medium from which bacteria and antibiotic sensitivities are identified. Now, cultures normally these days takes around 24 hours, then the presumptive diagnosis can be reviewed. Now, all major UTI guidelines, they do recommend culture for a UTI diagnosis. Now, the question is how many bacteria are needed to diagnose a UTI in children? Now, thresholds vary between different guidelines and collection methods. The commonly quoted threshold of 100,000 colonies per ml of a single organism is based on a seminal study in adult women by Dr. Kaas and his colleagues, and that was done in 1956. Now, does this threshold apply to children? Well, American guidelines suggest a 50,000 colonies per ml threshold with a concurrent pyuria for suprapubic aspiration and catheter specimens. More recent evidence suggests an even lower threshold of 10,000 colonies per ml, which slightly increases sensitivity without reducing diagnostic specificity. Many guidelines suggest that any growth on suprapubic aspiration is abnormal, as SP has got negligible contamination. While asymptomatic bacteriuria is the presence of bacteria in the urine without any active infection. We call it as ASB. Now, ASB prevalence is estimated at around 1.4 to 1.9% in childhood. Now, this bacterial growth without evidence of active infection, which we call as pyuria, does not suggest UTI. While in fact, these diagnostic thresholds are not binary, because low colony counts on culture may even represent early infection. It may represent contamination, or it might indicate an ASB. Now, pyuria may occasionally be absent in early infection or in some of the immunocompromised. Therefore, screening and culture must always be considered in the clinical context. And also keep in mind that contamination muddies the water when evaluating UTI. Now, assuming a single uropathogen causes UTI, multiple organisms simply suggest sample contamination. Incidental flora colonize the perigenital skin and can get flushed into the urine sample on voiding. And remember, misdiagnosis can occur if a true uropathogen is concealed in the mix, or misdiagnosis if a single contaminant dominates the culture. Now, contamination can be minimized by cleaning the perigenital area before sample collection and avoiding touching inside the specimen jar or like holding the jar against the child's skin. Now, also remember that current tests for UTI, they lack absolute sensitivity or specificity, as I said earlier. Urinary biomarkers such as interleukin-6 and neutrophil gelatinase associated lipocalin have been proposed to differentiate between active infection and asymptomatic bacteriuria. Real-time PCR has been proposed to identify common uropathogens such as E. coli, but further research is required to understand the clinical utility of these emerging tests. Now, coming to the treatment. Now, children with UTI require targeted antibiotics and supportive care. Well, most of the children with UTI can be managed at home with the oral fluids and oral antibiotics. Small percentage will do require admission for IV therapy, and that includes very young babies and very unwell children, those children who have got significant renal tract anomalies, and children not responding to oral antibiotic therapy. The choice of empiric antibiotics is guided by local guidelines, as local antimicrobial sensitivities vary significantly across the region. Now, the suitability of the initial agent should be reviewed once culture results are available. This is very important. Oral antibiotics are effective for the overwhelming majority of pediatric urinary tract infections. Now, previous Cochrane reviews have suggest that short 2 to 4 days courses are as effective as longer 7 to 14 days for uncomplicated cystitis, while single dose therapy is less effective. The American guidelines recommend that treatment durations of 7 to 14 days should be used for both cystitis and pyelonephritis, while the Canadian guidelines recommend 7 to 10 days. Here in UK, the National Institute of Clinical Excellence, which is known as NICE, their guidelines, they suggest 7 to 10 days for pyelonephritis and a shorter 3-day course for children greater than 3 months who have got cystitis. Younger and sick children may require IV antibiotic therapy. Many guidelines and centers at the moment, they recommend admission, IV antibiotics, and consideration of septic workup for infants less than 3 months of age. Now, one should aim to switch to oral antibiotic therapy after 48 hours if there is a clinical improvement in these cases. Okay, folks, now coming to imaging. Now, historically, guidelines recommended aggressive imaging follow-up to identify renal scarring and complications from UTI in the past. Now, it is now known that most of the children at risk of these complications, they do have structural abnormalities identifiable on ultrasound or having recurrent UTI. Therefore, many recent guidelines, they suggest less or no imaging after the first uncomplicated UTI for older children and less aggressive imaging after recurrent UTI. Still, ultrasound is the most commonly used imaging modality. Ultrasound is non-invasive, it is relatively inexpensive and an appropriate first-line investigation when an imaging is indicated. Now, this ultrasound can detect anatomical abnormalities in the urinary tract like hydronephrosis. It can detect hydroureter. It can detect obstruction or VUR. Now, NICE recommends ultrasound only for infants less than 6 months of age with first UTI unless infection is atypical or not responding to treatment. NICE approach reflects the view that routine imaging after all first UTI is not cost effective at all. However, imaging in younger children and other selected cases is more likely to detect findings of clinical significance. Remember, ultrasound cannot exclude all cases of VUR, but should detect most higher grade and what we call as clinically significant cases. DMSA scan is a nuclear isotope uptake scan. Reduced uptake of DMSA in the kidney can reflect either an acute dysfunction like pyelonephritis, or it can indicate a long-term damage like scarring depending on the timing of the test. Now, it is rarely required acutely, but it may help guide the long-term management. It may be indicated if UTI is atypical, if it is recurrent, or the initial ultrasound is significantly abnormal. Voiding cystourethrogram, also known as VCUG, it uses fluoroscopy, which is a real-time X-ray, to identify the course of contrast inserted by the bladder catheterization. Now, bladder filling, emptying, and ureteric reflux can be identified easily on VCUG. Now, while it is a gold standard for identifying and quantifying VUR, this procedure has a radiation burden and is quite invasive. So consensus for exactly who and how to image is lacking at the moment. Cost, invasiveness, and radiation burden must be balanced against the likelihood of identifying an abnormality, which may change the management for the child. Now, while most children with uncomplicated UTI outside infancy do not require any imaging, some children are at risk of long-term morbidity after the UTI. Therefore, targeted imaging and targeted surveillance strategies for these children with selected indications, it remains appropriate. So now coming to reflux. Now, historical approaches assume that vesicoureteric reflux could lead to significant long-term renal damage, and there should be identified early. However, there is now increasing awareness that much of the renal disease based on reflux is congenital, with an appreciation of mild hydronephrosis or mild VUR is likely considered as physiological states that resolve spontaneously. Now, given that lower grade reflux is unlikely to cause clinical significant scarring and mild scarring without other risk factors is unlikely to cause long-term renal dysfunction, or therefore aggressive identification of all VUR is unwarranted at the time. Active management strategies should still be considered for higher grade vesicoureteral reflux. Okay, and now moving on to recurrent UTIs. There are a few pragmatic strategies to reduce the risk of recurrent UTI in children. Number one, circumcision reduces the risk of UTI in males, but it involves surgery, with a number two needed to treat of greater than 100 to prevent one UTI here in UK. There is insufficient evidence to support some people call cranberry prophylaxis or probiotics. Antibiotic prophylaxis has modest benefit. It increases antibiotic resistance and is not indicated at all after first or second UTI in otherwise healthy children. Yes, for children with VUR, antibiotic prophylaxis does reduce UTI recurrence, but remember, it does not reduce scarring. It does not reduce scarring. A simple hygiene such as wiping front to back in females can avoid introducing bacteria into the urethral orifice. Similarly, active management of toilet training and constipation is very important to prevent functional bladder bowel dysfunction. Fine, to sum it up all, remember UTI is a common bacterial infection of childhood. As I said earlier, clinical diagnosis is unreliable, keep that in mind, and a urine sample is required for diagnosis. But remember, collection is not straightforward in pre-continent children. Dipstick, leukocyte and nitrate screening can inform initial management, but while you are awaiting culture confirmation. But remember, prompt management aims to prevent short-term morbidity such as urosepsis and long-term morbidity such as renal scarring. Keep it in mind that recent evidence supports less aggressive imaging following uncomplicated UTI. Also remember, antibiotic resistance is an increasing challenge. International guidelines have conflicting recommendations regarding sample collection methods, the duration of antibiotic therapy, and the indications for imaging. But last but not the least, targeted research is required to inform knowledge gaps and inform cost-effective care for pediatric UTI. So thank you very much, folks, for listening to this. Your questions and queries are always very welcome. I would say do subscribe to my channel and press the bell icon so that whenever there is a new lecture uploaded, you are notified promptly. So thank you very much once again. Stay safe, stay healthy, all the best. Bye.